Okay, all right. So let's kick things off. All right, Adam, thank you again for coming on the show. Really looking forward to this conversation around AI in the med tech space. A lot of great opportunities. Let me take a moment to introduce myself to the audience here. My name is Manny Bernabe. I am your host. I run an AI consultancy where I help companies kickstart AI and machine learning initiatives. Prior to that, I was at an AI IoT startup where I supported our medical device space and our vertical. So I spent a lot of time providing technical expertise to that group as a data scientist, as a pre-sales engineer. And so this is a space that I'm familiar with, I'm excited about, and I know firsthand some of the challenges that come with trying to do AI and machine learning in this space. So very much looking forward to having Adam on the show share his insights with us. This is brought to you by the Manny Bernabe Show. You can sign up for updates on at mannybernabe.com. So I encourage you to check out the website and sign up for our newsletter so that you get updates on future shows. With that, Adam, do us a favor, introduce yourself, tell us a little bit about your role, tell us about what you're responsible for, and how you're thinking about AI in your space.
Yeah, sounds good. Well, one, thanks for letting me come on the show. I appreciate it. Excited to contribute and just have a discussion around it. Obviously, a space that continues to garner a lot of attention. So my background, by training, I'm an engineer, by genetics, a salesperson. So I've been in sales now for a long time in med device, 20 plus years, starting, kind of outside the OR and then in the OR. And now recently, so I've been with Medtronic going on 18 years. My role now is a little bit different. So as we have seen this huge site of service shift out from acute care to ASCs, I've kind of jumped in to do quite a bit of strategy when it comes to how we work in that space. That does provoke a lot of questions when it comes to AI. One, you always have these questions around how do we pick the right patient that should go to that right side of service, lower acuity. So there's some analysis there. So I've started to continue to look at questions along those lines of what does the ASC space present to us as a challenge that in acute care may not necessarily. So my one role is strategy. My other is really trying to develop, what else we can do in this space outside of our products and procedures. So you look at the right patient, but it's also what at this service level is a little bit different. How do we identify the right patients to treat, the right level of intervention? Um, and what's unique about my role is I'm not specific to one product category within Medtronic. I sit across anything from Medtronic that comes out into the ASC or office-based lab OBL space. So I get to look at everything from cardiac rhythm to pain management, you're really anything in between. So it's a wide scope of products and procedures that I get to have visibility to.
That's very neat. Can you talk a little bit about some of the use cases that you're looking at for AI and machine learning? What's getting you excited?
Yeah. So there's a couple big ones. I mean, you look at the amount of data that we've got, whether it's within my organization, and I should probably point out these are my opinions and my opinions alone, but within my organization, we've got a ton of data. So how can we best leverage that data to do some of those things where we're trying to identify the right patient at the right site of service, potentially identify additional interventions that are appropriate for that same patient that might be in that physician's group. So I want to dive a little deeper into that one in particular. So we're not trying to overtreat or treat a patient that doesn't need an intervention, but essentially, if you really boil it down, when we've got some of these CV-related ASCs, essentially a lot of it is plumbing, right? It's the engine, the heart that's driving it, and then it's plumbing. So if we could somehow predict that somebody might have a peripheral vascular need for intervention, something along those lines, because you're treating the whole patient now in some of these ASCs, that's something that really intrigues me to figure out what we could do there. Also, this potential for digital twins. I'm sure we'll talk more about that, but this whole ability to try and trial something on a patient without it being the real patient would be huge for med tech in general, but also how would that apply to taking a higher acuity patient, potentially figuring out a way to intervene at a lower acuity facility like an ASC. So that's a lot of what I've been looking at. I'd say one last thing, and I posted some stuff about it, was this ability to appropriately predict If there's an intervention that would avoid a lower leg amputation in peripheral artery disease, there's an awful lot of amputations. My dad's a diabetic, so when I start to look at some of the downstream impact of that disease, is how could we one intervene, two how could we predictably intervene early enough in the process or in the patient to avoid that amputation, and that is part of the challenge is prediction early enough for it to be of impact. So
Those
those are
those are
yeah.
great. Those are great case studies. A quick clarification for the audience: AAC. What does that stand for?
So ASC, ambulatory surgery centers. Now,
Ambulatory
yeah,
surgery
so
centers.
there's a
Got it.
huge shift right now. Just Medicare has made some recent changes over the last year or two that has allowed, especially cardiovascular procedures, to shift out. So if you're looking at peripheral coronary disease, peripheral artery disease, PCIs, even primary ICD implants, so pacemakers, all of those can theoretically be done in ASCs in certain parts of the country. That really is a different dynamic because, as you can imagine, those can be patients that have a lot of other comorbidities.
Got it. Now that makes sense. Thanks for that clarification. For those folks in the audience that are not familiar with the medical space, and so you mentioned the right intervention for the right patient. So looking at the details for that patient and saying, hey, in addition to this particular treatment, we also recommend X, Y, and Z, and let's follow up with those recommendations.
Yeah, potentially, or if you've got a hospital system, they're trying to figure out where to treat which patient. If either A, they've got such a backlog to treat patients, or B, they want to make sure that they're going to leverage an ASC because an ambulatory surgery center is usually a lower cost to treat a patient. So when you're looking at the total cost of care, if a hospital or physician group can say this patient is okay to go to an ASC, it may decrease the overall cost of that case. But the risk in that is if you take the wrong patient there that has higher acuity or has a poor outcome, that could really challenge one, the patient, right, put them at risk, but then also then they're going to end up back at the hospital anyways. So not a perfect solution for AI, but I think we could help predict which patients could do that along certain lines.
Perfect. That makes sense. ASC, it's almost like it's not quite all the care you might get at a hospital. It's more, it's leaner and
Yeah,
potentially
exactly.
more convenient for the patient. But there are going to be times when you don't want to send a patient there. You want to send them to the hospital because they're going to need that extra level of care.
Right, right, and again, something I want to touch on a little bit later in the discussion. But if you've got a smoker that's overweight, diabetic, chances of them doing any sort of procedure in an ASC should be probably relatively low, just because that intervention comes with a lot of risk because of the patient. So those are easy ones to probably flag in like an EMR or an EHR. But there might be other underlying things and that's where I think AI could really find something. Is there might be something else, a contributing factor that we aren't necessarily paying attention to, that AI could flag and say, well, maybe this patient as well shouldn't go or could go because of some sort of weird correlation.
Right. I've also seen instances in other spaces of using AI and machine learning to match the case to the appropriate service provider. So
Yeah,
you might have 10 nurses, for example. Some of them have expertise in certain spaces. Some of them are more senior. Some of
right.
them have different attributes. And so depending on the patient, you might want to route that patient directly to a particular type of provider.
Yeah, exactly, exactly. Yeah, and I think there's value in all of that. So when you're looking at data, that's one I think real advantage. The other thing I look at quite a bit is imaging. So when you're getting into peripheral artery disease, you're using ultrasound all the time. You're using C arms to be able to figure out where you're doing the intervention. All of that imaging data comes with the ability to potentially catch something else. Could AI catch something that maybe we're not used to seeing? Or could we leverage it to say, as we did a scan of the mid thigh, there's something that's 3 layers deep that the human eye can't pick up, that because we have so many of these images, we can flag that, oh, you might want to do an intervention here as well. So that use of tabular data is one, the use of imaging is another. And I think there's a real sweet spot of trying to use potentially both. And that's where obviously a lot of complexity comes in.
And the benefit there is that if you have to come in, maybe you have like a broken finger or something, you do some imaging, and you're there for the broken finger, yes, but then the image you might catch something that's a little bit
Right.
more, something that wasn't detectable until then, and potentially help you get a head start on that, so to
That's
speak.
exactly right. Yeah. Yeah. That's kind of the general, I guess, hope I would say. As I did some of the early stuff, and I feel like I should throw this out. I'm very generalized when it comes to AI because I'm not in one of these sweet spots. But seeing kind of this application across all of these different areas is exactly that. Could we identify and predict something to happen based upon images that we have? And then, as I mentioned earlier, can we predict it early enough to make an impact to help the patient? That's I think another really important thing. But so in general, though, you also look at the efficiency of care. So as we go from you can treat all the patients in an acute care hospital, there is this centralization of patients there, right? It's a little bit easier to treat them all. Well, now if we're going to surgery centers, they might be spread out all over this city. And that, to your point, it's convenient for a patient because now they can get to a surgery center that's right next door. But now you've kind of decentralized that patient population. So how could we potentially manage the fact that you don't have a centralized patient population? We still want to identify interventions. We want to be able to triage and treat the appropriate ones more quickly. It becomes a little bit more complex, right? Because they're not
Right.
all just sitting right there with all the specialists right in the acute care hospital.
Right. There requires a little bit more planning, so to speak.
Correct. Yeah, exactly. So
More
case
design.
management or efficiency, and then you look at the efficiency of being able to have AI either scan images, assess and triage a patient more quickly. So you've got all these patients that are coming in maybe on a referral. It's not an emergent procedure, but they still need a procedure. They've got a lot of peripheral pain. How do you then triage that, make sure they're getting treated more quickly? And I think that's a really interesting application of AI as well, is this triage applicability, and then
Eh,
the management thereof.
Right. And Adam, you mentioned something that I think just I've seen in other spaces is that this is data that you already are creating and managing, but you're just repurposing it for something else and creating additional value on top of
Right.
what you're already doing.
Exactly. And yeah, I think you nailed it. I think there's some real value in the fact that we already have these data pools. I think what we run into is that everybody owns a different data pool. And are we willing to share those data pools, right? We as a company might have some, you might have some in the physician group. There's real concerns about HIPAA, right? We don't want to overshare or share to the wrong person. So you have these different data pools, number one. Number two, they could be structured data, unstructured data. So then you look at this application of like native language. How could we apply something like that with AI to then be able to kind of pull all these things together so that it makes sense? And that's, I think, another really strong application of AI is when you start to get into native language processing, things like that, they could pull out and connect these data pools that we have. Because I can guarantee you, although they might be considered, we'll use air quotes, structured, they're probably still not structured the same way.
Right, right. And Adam, I like the fact that you're talking about these different types of technologies. So for everybody else in the audience, natural language processing, we're looking at text, we're extracting meaning from that. Adam mentioned imaging, so we're looking at pictures and we're trying to have a machine learning program make predictions and labels based off those photos. And of course, we have the standard tabular data where you might put in, hey, I was a smoker 20 years ago. This is how much I smoked, or I have diabetes.
Yeah.
That's all data that's being captured and put in a database. But the promise of AI and where I think we're going to get a lot of benefit is when we're able to bring all these different data sources together and provide a complete view of the patient for the patient and also for providers as well to make very strategic decisions about where to send them. Like, oh, you need to go to this center here because they're going to be perfect for exactly what you need right now.
Yeah. Yeah. That's exactly right. Yeah. Yeah. Good summary.
Uh, Perfect. And then you mentioned a second use case around digital twins, and so I'll just recap that so that for our audience. But the idea there is let's create a simulation based on your data, information, what we know about what's going to happen with treatments and procedures, and let's do that in a digital fashion before we actually give you the treatment
Right.
and find
Right.
out what happens. Right?
Yeah.
It can be
Yeah.
very convenient. Talk to us
Yeah.
about that. How do you see that shaping out?
Yeah. So one, I don't know as much about pharmacologics, right? But if you get into anything that you're going to take into your, a chemistry change, That would be really interesting to see how that plays out. And I know there's a lot of applications there already. Some of this stuff, I took a real quick certification class through Harvard Medical School on AI. It was fascinating. And I'll be honest, I understood like 10% of it, right? I mean, it was like me using my iPhone. I didn't get nearly as deep into it as I think you probably could. But some of the applications there from a pharmaceutical standpoint, to be able to leverage that digital twin to say, okay, this is how we're going to intervene. How does that interact? And how does that affect an outcome before you give that drug to the actual patient? I think that's one. The other is if you look at, if you're going to do some sort of cardiac rhythm management, we would do this on the digital twin first and then see what that does to the real patient if it seems beneficial, right? There's still a big bridge there, but the ability to try and kind of predict what's happening in a digital twin would be huge. But then I also look at, diabetes, impact of diet. Okay, if the intake on the digital twin, we alter this, we decrease levels of intake in this form or fashion, we monitor carbs, what happens to the A1C with the patient in real life or on that digital twin? So yeah, the ability to be able to experiment. And the one thing I'd say is I think we're getting closer and closer to making a real digital twin. I can't predict how far off we are, but you look at all of the inputs in the data. You've already got stuff we know about EMR, EHR. Maybe you've got something from a device you have implanted, but then also you've got all these wearables, and then all of these other things and apps that can feed into it. And so you've got wearables that if you ever track your diet already, you've got diet apps, so you can start to get a little bit more of a holistic picture already. Not complete, but I mean, look at all the data endpoints. If you start to get imaginative, that you could really feed into telling me more about you in a digital fashion.
Spot on. And I want to encourage everyone to drop your questions, your comments in the chat. One of the nice things about being live is that you get to be part of the conversation. So I guess I would ask the audience, what do you think is the best use case for AI in the MedTech space? Which one is resonating with you? We talked about predicting the right care for the right patient, digital twins, and some other challenges around data silos. So tell us what you're thinking about that in the comment section, and we'll bring them up. Adam, you bring up a good point around wearables. So like I know, at least in my group of friends, the Whoop, the Aura Ring, Apple, the Apple Watch, we have a ton of data available to us as consumers, but I don't feel there's an easy way to quickly plug that into my healthcare provider's system. Is that fair? And if so, why is that the case?
Yeah, from what I've seen, I think you're right? We haven't enabled probably the sharing of that as much, albeit I'm not totally sure how many people would want to share, right? There was an athlete that I know that she wasn't real excited about sometimes how like on point that Whoop was, right? Like she had too many cocktails the night before. It would flag her on it, right? And call her out. So, some of that is how much can we share? I know there's a couple applications out there, and I'm sure there's more that I just honestly haven't seen that does facilitate it. But I do think as when we look at like the world of insurance, I'm not a smoker, I'm not a heavy drinker, I exercise daily. I'd love for that to start to burn down, how much I'm paying in insurance. I don't know that we're there yet. I think there's enough conversation around it though, that there's a real potential there, that they can start to take all that wearable data, maybe apply a different insurance premium, but more importantly, tell you like, okay, here's the trajectory of what you're looking for 5-10 years down the road. You might have a heart condition, or if you continue down this path, here's what might happen to you. And I think that's the real question when we look at some of these things, Manny, is if we know it and AI can predict it, do we change it? Are we going to change it? Are we going to really go eat that vegetable instead of the cheeseburger, right? A lot of these things we already know. So are we really going to change it based upon what AI says?
Right. No, that's right. That's always going to be the kind of the question. Ultimately, you'll get recommendations, but you still have to follow them, and that's still going to be tough, right? Because that burger is very tempting. I have a question here from the chat. Unfortunately, I can't bring it up on the screen, so I'll just read it, Adam. So we have Aaron asking, Adam, do you see these wearables as partnerships with providers, or more along the lines of going it alone as a supplier, as a product offering?
That's a great question.
Great question.
Yeah, I mean, that's, I wish I had an easy answer. I'd love to take the easy out and say probably both. I mean, I've seen it applied in two different ways. I've seen some total knee vendors that as you've got an orthopedic implant, they're going to have some sort of tracking and modality with that. You know, one of it comes important when you're doing rehab that you're getting up and moving more quickly. So they're going to track it. They might either give you a Fitbit pre-op or post-op to be able to kind of track that activity. So I could see that from a provider perspective on the Fitbit side, or that wearable that you're going to put on the implant from the vendor side. So I think honestly, I think there's a business case for both. I think it depends on what kind of intervention you've got and what kind of outcome you're trying to drive. So I would say both, but phenomenal question.
Yeah, no, I agree. I think it's going to be tricky, and there's going to be a real opportunity for the healthcare system that can really integrate all these different third-party data sources into their system. I'm sure it's going to be hard because you mentioned the regulatory issue, the legal issue, and not to mention the technical part of it. How do you plug in from all these various sources via API data in a secure way that seamlessly plugs into your ERM system and can present it to the doctor and to the nurse in the right way? I'm sure there's some privacy things that you want to be concerned about there as well. So I think it's going to be a very difficult nut to crack. But that said, I only see wearables becoming a bigger part of everyday life. Right now, I'm sure it's just like the big time athletes that are wearing the Whoop and all that, but pretty soon it's going to be like 50% of the population that's going to have these wearables. That's going to be very valuable information to any healthcare provider.
Right. Well, and have you seen in the spectrum with wearables, right? They went from a toy to now people are leveraging them for actual impact. And to Aaron's question, right, that changes. I think we're starting to trust them. We think that they are deriving the right output, right? You can actually monitor your heart rhythms and stuff with it. They're not just telling you to stand up because you've been sitting for 30 minutes or whatever. So I think that trust in them is going to come up. I just want to call out, though, you did say the S word. In healthcare, seamlessly is the right is the S word. Nothing is seamless, right? You just want to plug some application in. It's never going to happen. You've got EHR, physician groups, they're all doing different things, right? Then you've got a vendor that's going to try and port into the data. There's a real challenge there with quote unquote seamless integration. Not as I think it could be. And then you've got cloud-based. Cloud's got to be secured because you can't have that data leak out of the cloud.
No, perfect. You mentioned seamless integration. That's a challenge. We talked about data silos being a challenge. What other challenges do you see in the way of realizing the full potential of AI in this space?
Yeah. So, I think the other one is really, there's two. One is, does the patient then alter behavior based upon what AI is saying? That would be one that we touched upon a little bit already. So I won't belabor that one. The second one really is can we identify whatever the intervention is fast enough or early enough? You look at some of the AI applications in stroke. You've got a finite window of time to be able to identify a patient that has had a stroke and then try and get them to the right intervention. I think there's some that are doing it really eloquently in the market right now, but that I think is a good metaphor or sample to use when you're looking in other areas. Like, how early can we find that intervention and rapidly triage it and treat it? When you look at imaging, the other opportunity there is this identification of, a lot of times it's cancer through an image. For AI to identify it is fantastic. We've also got to make sure that it's not overly sensitive. So it's not flagging something too much, because then you're not increasing efficiency in the system, you're decreasing it. So I think there's a real balance there, is how can you be precise enough to trigger something in an AI system, but also accurate, so that you're not then taking somebody to annotate, go back and educate all the pictures that you just took. So I think that's still a hurdle of precision versus accuracy when it comes to whether it is image or data.
So, spot on. So you mentioned making the prediction within the right window. So if there's a stroke happening, you have a very narrow window in which to make that prediction. That's going to be helpful. If you do it too late, then the patient's gone past the golden hour. If you do it too early, then you're going to get a false flag. But then you also mentioned being overly sensitive. You're right. You can build systems that are going to flag on every possible alert, but you're also risking a lot of false flags, and that's going to lose credibility for your product with the patient and the provider. So they're going to see all these red alerts and they're going to be like, oh, this AI thing is always flagging and it rarely ever happens. I'm just going to ignore it altogether. So that's another challenge. I think the other problem in this space as well is measuring the effectiveness of a prediction. So if I say like, hey, like you have to do this treatment and it's the correct one, well, I don't know about that because the patient never came back in, right?
Yeah, there's this whole kind of symbiotic relationship that you've got to make sure that they're coming back and telling you, or there's another use case of wearables, right? Is, okay, I'm going to have you do this intervention, but you have to wear this as you leave, whatever that might be, whether it's managing heart rhythms or pacing or whatever. But you're right. I mean, I think that's a real challenge, is that follow-up. Did it really make an impact? And again, especially if you've got somebody coming from a rural community into downtown and then back. You live in Chicago, right? Just to get from Wheaton to Chicago, that could be 90 minutes depending upon the day. So, do the patients always come back, and can they get access to what their outcome was?
That's a great point, Adam. Sorry, I got to double click on that, or just highlight that wearables as a way to measure the effectiveness of a treatment post the visit to the healthcare site.
Yep, exactly.
That's a really good use case. So, sorry to interrupt. Go ahead, Adam. What were you?
No, I was going to say the other thing too, that as far as a limitation of AI in healthcare is, we talk a lot about brittle models, and I think that's something worth highlighting, is that we've got all these data pools we talked about. Then you start to maybe plug in a wearable or something else as far as an input feed. I don't think we know enough yet of how quickly a model can become brittle with all these data points in healthcare. Where the model essentially breaks because you've got one more data pool, or you tried to tweak something or whatever it is. I think there is a concern, at least in my mind, about being too brittle, that the model breaks down with one other data source.
That's a great point, and I'll provide some context for everybody else. So what we're doing with models is we're looking at historical context, and we're encapsulating that in a mathematical way and building a model off of that, so that then we can use that in the future on new data. So if we know that every patient has reacted in this way in this 20-year data set, then we can apply it in a week from today for a new patient. That said, sometimes the future does not look like the past. Sometimes the new patient isn't represented in that historical data. And so you may have your model lose its efficacy over time, and you have to monitor it continuously. Sometimes it's a very fast drop. Sometimes it's a subtle drop, but it's hard to predict. So to Adam's point, like, this brittleness is something that we have to be very conscious of as we're deploying models into the wild and into production. I think a lot of folks, there's a lot of effort that goes into building the models, and that's really hard. But then you run out of steam a little bit in terms of monitoring them post-production. But that's when you have to actually increase your vigilance to make sure that model is still performing at a good level.
Yeah.
We got a question here from the from the audience, and again, I apologize. I should have these questions coming up on the chat. They're not, but I will read them to you, Adam. We have Kevin asking here. Adam, I know that digital twins have been useful in manufacturing models. What specialties in healthcare do you see moving most towards modeling clinical care around creating a digital twin or simulation to treat patients?
Yeah. So good question as well. Pharmacology or drugs. I mean, I think that's probably one where you can have, and I try and break it down as, like my old engineering mind of, okay, what's an equation that can be adjusted, right? We think of a digital twin. In my mind, I'm thinking like, we've got like an actual cyborg or something here, like in some sort of gel-like substance that's floating. It really breaks down to equations, right? So I think that the use of chemistry, when you're looking at the equations and the impact on a digital twin, I think that continues to be a really big one. On my side of the fence, when you look at electrical manipulations, so electricity, again, to me, boils down a lot more to math. So if we have this sort of heart rate, or we change the rhythm, or we have this sort of impulse, I think there's the other real application as well. I think as we get further down the line, maybe a 5 year window, I think you really start to look at maybe the application of diabetes or chronic disease that could be impacted by a digital twin. You start to tweak nutrition. Again, it's chemistry, right? You start to tweak carbs that are coming into the body and the downstream impact of that, and then really is kind of a long-term impact on that digital twin. Because I think that is the one other advantage that I would love to explore more is how fast could we bring in some of those time frames. We look at how long it takes to create a drug or how long it would take to see an impact on a patient, especially from a dietary perspective. It could be 5 year window. With a digital twin, can we collapse that to a month for instead of 5 years? I mean, I don't know. I don't know how much we could impact that, but that's what I would love to see. So those are the three main areas I would see: long-term, chronic, if you're looking at the electricity in the body, and then pharmacologic intervention. I would love to know more.
Great question. Thanks for your thoughts there, Adam. Now, Adam, you're not a data scientist or a statistician by training.
Right.
You're an enterprise leader. You manage a number of different verticals, but you appreciate that AI and machine learning is going to be a big part of your strategy moving forward. Talk to us about your journey in terms of getting up to speed on AI and machine learning, which I've seen and it's been very impressive. Talk to us about that.
Yeah. So a lot of it is, recognizing the patterns, and that we, I've been with this company now for almost 20 years, 18 years, right? So I've seen how much access we have to data, potentially both internal stuff that we have plugged into an EMR. And I've also seen the paralysis of there's just no way to aggregate it at all and really put it to use. So I would say 2-3 years ago, really started to try to be intentional about, how can we use it? Where would we use it? With this transition into ASCs, ambulatory surgery centers, is then really trying to solve the problem of, are we treating the right patient at the right place? Is there other interventions we could do for that same patient that would be beneficial and provide an optimal outcome? Those things kind of all came together at the same time that I think AI has flipped this switch, right, in MedTech over the last 3-4 years, where there's a little bit more of an acceptance to it. So with kind of the climate being right, that's where I really dove in. There's some easy courses on Coursera that I took, with Andrew, right, from Stanford. That was a great introduction to AI. That was kind of the basis of it. Thankfully, at the company I work for, there's a ton of courses you can actually take internally because we have so many different AI applications already in use. We've got them in spine, we've got it in cardiac, we have them in GI. So when we start to look at those, I got to do kind of a deep dive into those to expand my learning. And then a lot of it was kind of going out on my own as well. So towards that Harvard Medical School class, it was AI and healthcare. I thought it was great. Again, they've got some extremely brilliant people on there. But I still learned a good bit about trying to restructure my arguments, how you could be predictive. And then I've continued on. So right now I'm in an MIT executive class, again, same thing, trying to get exposed to different elements. It's not all AI, but it is bringing in different critical thinking into data, into AI kind of as we progress through. So, I've just continued that journey, and that's where I'm excited to see where things continue to go. And honestly, I appreciate being on the call because those questions we got, those are phenomenal. Those make me go back and think too about how else could we deploy wearables? What else should we do with digital twins? It's a good provocation. Yeah.
I really like that approach. And you talked about the MOOCs, the massive open online courses.
Yeah.
These are courses that are available for free or for like $100 on places like Coursera, edX, and they're led by world-class professionals. They're on demand. So that what I always recommend for folks, especially if you're not a technical person, just watch the first 25% of that course. Generally, they start off very broad, give you a general view of what is AI, what is machine learning. So that is in itself is pretty helpful. And then there are also courses that are specific to AI in the medical device space or in the healthcare space. I'm sure there are a couple on Coursera that I'll find and I'll link to. I know you mentioned that, but this is specifically AI for healthcare. And again, you don't have to watch the whole thing. The first 25%, 50% is going to be super helpful, and you're going to get a nice sort of lay of the land in terms of what's happening in the space. You also mentioned your Medtronic offers a lot of internal courses as well.
They
That's
do.
such a smart move. That's really cool. You and there's one course in particular that you really appreciated. Can you tell us a little bit more about that one?
Yeah, you're saying the one internally with Medtronic or
Yes.
externally? Yeah. So there was one. It was AI considerations for management, and that's where again, I'm sitting at not because I'm at a management level because I'm not a data scientist. I needed something that was a little bit more general, and it really walked through though it bridged the gap of here's the idea, here's the application, and here's the challenges we had before we deployed it. One in particular was on the spine side where we have a technology. It is AI implemented to predict that if you have this intervention of a spinal fusion, what will happen to the rest of the spine. I do found that phenomenally interesting that we could start to predict that, but then you put in the real world part of it, and you touched on earlier of regulatory approval. That is no joke when it comes to med device in the first place. But then when you talk about AI and you talk about a predictive tool, it did get FDA approved. And the part around that, I think, is that you really start to look at, all the stuff we're talking on today is challenging for all of us to really kind of wrap our minds around, right? AI in general is relatively new. Well, it's also new to the FDA. So when you're looking at trying to get something through that's a
Right.
predictive tool for, spine curvature through the FDA, utilizing artificial intelligence, that's a mouthful, right? And they did it, and I thought it was phenomenal to be able to see kind of the inside track of that, what the processes were, and to investigate that further.
That is so neat. And was that led by a fellow Medtronic colleague and specific to what you're doing, what Medtronic is doing in that space?
Yeah, they have a whole group that's basically associated with it. They kind of brought in guest speakers, but there's a crew of 3 or 4 that really kind of facilitated the conversation. And again, it's pretty high level overview, but when we're doing in cardiac rhythm management or what we're doing like with the pill cam, right, identifying tumors as you're going down. I mean, that some of that stuff they pulled all of that together essentially, and then they hosted. I think it ended up being a 3-week course. But again, great, just open eyes to what's happening.
That is such a smart move. That's really very neat that Medtronic is doing that. What you find is that in most organizations there are pods of AI that are happening throughout the organization because in many respects AI is a tool, and so
Yeah.
it's usually the business units that are using it as a tool for their specific use cases. But there is a lot of interest across the entire organization. Not everybody knows how to approach it
Right.
to the extent that you can facilitate that transfer of knowledge within the broader organization,
Yeah.
share what's worked, how is it useful in real to that particular company, to that particular industry. That's going to help quite a bit. And I think the other result that I've seen is that you're connecting the different AI interested parties across large teams
Hmm.
to have some sort of connection to start driving momentum and
Right.
share more use cases, right? I'm sure
Yep.
once you've gone through that training and you see something else interesting, or you start doing your own projects within your own spaces, you're going to reach out to the
Yep.
team like, hey, like this is what we're doing. You mentioned that, like check
Yeah.
this out. And they're going to share that with someone else, and that starts building momentum internally to make the organization more AI and machine learning savvy.
Right. Yeah, that's exactly right. Yeah, I mean it's a nice cycle, right? And I agree with you. I'm excited that they put that together, to be able to go through it and then to meet all these people internally that are already doing it that are far broader than I am when it comes to AI, and then start to kind of glean and say, well, would this work in this space? And to have somebody to bounce it off of. Yeah, it's pretty phenomenal.
And then we also talked about annotation being a big challenge, that being
Yeah.
one of your aha moments. Talk to us a little bit more about that.
Yeah, so I mean, going into it, I didn't really think much about it. So one, they talk about the cost, the budget to try and put something like this together. Well, when you start looking at if you've got 1,000 images you want somebody to annotate on, right? Well, that takes a certain amount of time. Well, these people aren't free, nor should they be, right? So you've got to try and start to accommodate one, the amount of annotation involvement in a budget, but two, it also be the level of annotation to basically make sure you've got the right sample, right? That you've got some sort of base truth, which I think we can get to. We've got enough physicians obviously could provide some base truth, but then they've still got to go back and continue to identify like, is this really what we're seeing in whatever the image is. I vastly underestimated that, and it is a point that I want to bring out as well. Is when we look at AI and MedTech, one of the critical things is we're never going to pull out the clinician altogether, right? That's not the point, because there is still this value that a clinician has, that they're going to have a different level of ability to understand what's going on with that specific patient. All we're looking to do is augment their skills. But back to the point of annotation, they're always going to be involved. So there's that level of how do I continue to get that level of annotation involvement. So it was just something that I learned along the way that I hadn't paid much attention to.
A great point. The fundamental promise of AI is looking at historical data and teasing out signals, but you have to feed that data into the model or into the algorithm in a very specific way. And oftentimes, the biggest pain point is in getting the label. We call them labels, but you're calling them annotations. But it's the same. Imagine you have 1,000 photos. Some of them are dogs, some of them are cats, some of them are birds. Well, someone has to go through that and say, this is a bird, 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 dog, 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 cat, cat, cat. And then you can feed that into your model. And then the model will tease out all the different attributes of what makes up a cat, what makes up a dog, what makes up a bird. But that upfront work of labeling that is really, really important. And to your point, you mentioned that, but you also mentioned what proportions of birds, dogs, and cats you put in that data set, so that that model has sufficient information to make that broad generalization.
Right. Exactly.
That is, yes, you're right. That's very underappreciated, and especially in a skilled profession like reading X-rays or other imaging, that can be very expensive, very time consuming.
Yeah, that's exactly right. Yeah.
And you also, I think I really like your point around framing AI as something that is augmenting the end clinician and the end practitioner. You're 100% right. I think we're going to, autonomous healthcare is probably way off into the future, if at all. There's just so much nuance, so much detail that goes into one individual case that you're always just going to have that framework. And I think we need to make that point a little bit more. Have you seen that be a little bit of an issue as you're talking about AI with clinicians or practitioners?
Yeah, I think there's a certain amount of it, like how much do they trust it? And it was, through some of these classes we were just talking about, where they highlight different studies where there was a physician that annotates and they were right 9 times out of 10. Well, that physician trusted AI less because they were right most of the time. But then there was another one, and whether it was a new physician or a physician that didn't annotate as well, maybe they were right 7 out of 10 times. Well, they trusted AI more because it helped them get back to the median line. So there's this constant balance of, number one, how do you deploy the tool that you've got? I think that the Harvard class really brought that to light. How do you intend to use the tool? And then once you use the tool, what are you really doing with that physician? What's their level of involvement, engagement, and how much do they trust the output of it? And are they really going to rely on it when you're flagging the system? So there's a lot of different elements to take into account when you're starting to deploy a model and a tool.
100%. And I'll mention that I'll have show notes for this conversation shortly by tomorrow. And so if you're looking for the links to these different courses, we'll send them. You'll find them in the show notes. Yes, I think I'll also say that it's important how you present the information to the practitioner. So if it's just a black box where you say, like, this is the recommendation, this is the recommendation, you just got to go with it with no explanation, then good luck getting the doctor to follow that recommendation. It's much better if you say, here's the general recommendation. Here are the 4 themes that kind of got us to that. And then here's more detail on that if you want to find out. So using it, and then that way you get the recommendation, but it's also helpful for you to show the practitioner how the AI got to that point. It's an angle that they maybe hadn't considered and hadn't seen, or referencing some other data set or study, but that is just as important as the overall prediction.
You nailed it, man. Look, we're like 3rd grade math, right? You got to show your work.
Right.
Look, it's different, right? When you can't necessarily show your work, because the AI model sometimes comes out with a prediction that we don't necessarily know the exact way they got there, right? And that's really an unconventional way of thinking for an engineer that goes A equals B, B equals C, or a physician that knows exactly how they're treating this patient. All of a sudden you come up with this model that says, maybe you should do this. Why? It's just what the model says. That's not a great answer, right? Now, I'm not saying that they don't always take some, they could take that as input, but that black box part of, AI becomes very tricky when you get into MedTech. Yeah, well said. I'm glad you
It,
brought that
it-
up.
right, and there is sort of there's a gradation, there's a spectrum, I would say, of very simple model to very complex model.
Yeah.
And like in most things in life, there's pros and cons. You can do a very simple model, but it may not be as accurate, but it's going to be highly explainable. I can tell you, like, oh, these four variables went into it. Here are the loadings for each one of those variables. Here's what's driving that. Or you can have a very complex model and it can be super accurate, but it's more black box. I can't really ascertain why the machine learning model algorithm came up with that solution, but it tends to be more accurate. So I always recommend, as you're starting off your AI and machine learning initiatives, err on the side of more simple. It's going to help you figure out, what service value you're actually adding to the customer. And then it also has a byproduct of it being easier to deploy as well, and a little bit more established. So you're not spending all your time solving technical problems up front. You're solving more the value case and more the user interest case, more so than the technical part, which is what I always like to focus on for AI projects at the beginning. Later on, once you establish all those other details, then definitely double down, go, do deep learning neural nets, other more complicated algorithms. But
Convolutional neural networks. I don't even know what that means. Yeah, exactly. Yeah,
right.
yeah.
So on the simpler side, you'll hear terms like linear regression, logistic regression. On the very complex side, you'll hear terms like deep learning neural nets. Deep learning neural nets, that's like all the rave. That's like AI, that's Google AI, all that stuff. And ultimately, it's great to be able to get there. But starting off, start simple, make it explainable, make it easy to deploy. It's generally my recommendation.
Yeah. Yeah, I
We
think
have a
the one thing I would say is if you're looking at all of the things you've got to do when you're trying to deploy a new AI model in healthcare is you've got regulatory concerns, annotation, what's the data input, etc. I think that what's really got to be the guiding principle is ultimately what are we trying to solve for that patient. That's one thing that I think the organization I work for has continued to drive at. It's been really my drive over the last 25 years in healthcare is ultimately there's a patient at the end of that we're trying to make a positive impact for. Everything else becomes secondary to that, but we've got to drive to what is ultimately that impact we're trying to have on a patient.
That's a great way to end it. I really like that. I'll add one more comment from the audience. Doug Shannon here saying, great conversation and information here. Thanks for speaking on these topics, Adam.
Awesome.
I also want to join Doug in thanking Adam for coming on the show and talking about this very important concept, and him sharing his journey and what he's found out. Really helpful. I will have a replay of this and show notes out pretty shortly. So follow me on LinkedIn to see when those come out. And as we close out, Adam, how can people get in touch with you? Should they follow you on LinkedIn? What's the best way for people to follow your work?
Yeah, LinkedIn's the best for sure. Yeah, I'm happy to connect. I'd love to connect, actually. I mean, you asked earlier, how did you jump into it? I connected to Manny on one of his shows, met some other folks on there. I mean, reach out. I'm happy to try and connect with you, tell you how much I don't know about AI, but happy to tell you, what I've been working on. So yeah, feel free to reach out, ping me on LinkedIn. I'd love it.
AI is new to everyone. Anybody who says like they know it, I know everybody's figuring this out, and it's important that we have these conversations to help each other make it real, make it valuable. Very neat, Adam. Thank you so much for coming on the show. Thank you, everyone else, and we'll catch you on our next show, which is going to be about AI in space. I'm talking to a AI company called Wallaroo, who just landed a contract with the U.S. Space Force around leveraging predictive analytics for satellites. So that's coming up next week, Thursday, September 1st, excuse me. So tune in for that. It's going to be a great show. All right. Thank you, everybody.